this, well, first off, I'd like to give some thanks here. Sorry, I got to read this first, though. I do not have any financial interest of a product in my talk or any companies offering grant monies for this continuing dental and medical education program. Thank you. All right. So, yeah, first, some thanks. Number one, thanks to Rich Fisher for having me present this. As we all know, Rich has incredibly good taste in the selection of speakers. And also, thanks to a lot of the IAOMT administrative team who, they always do a great job putting things together and keeping me running on schedule. And then, of course, all the other people in the IAOMT who have really kind of paved the way for this, because without them, yeah, none of us would be doing any of this. And of course, most importantly, thanks to my wife for putting up with listening to this lecture countless numbers of times. Go ahead, stand up. She's the brains behind this anyway, because you know she's that rare combination of brains and heart, and I appreciate it. So, speaking of brains, we're going to have to kind of put on our thinking caps here a little bit, because perio is not one of those topics that lends itself well to simple discussions. And for a long time, perio has been kind of relegated to like the worst topic in dental school that you have to deal with. It's not sexy, it's not easy to understand, a lot of immunology, a lot of biochemistry. So I'm going to do my best to try to make this as interesting as possible. Now, like so many other topics in dentistry, unfortunately, perio has been a victim of this kind of dumbing down that we've done with so many other topics, asking dentists really not to think about this too much. So here's the way, and you know, this is a common theme that runs through dentistry, is that when you have these concepts that you want to try to get dentists to accept, and that are complicated, you take this whole big set of facts, and then what you do is you kind of peel away the ones that don't really fit in with your thinking, because dentistry tends to have a lot of agendas. And in this case, the agenda tends to be the fact that we don't really want to think about this as a whole person issue. You know, we want it simple. So what we do is we take away all the facts that are really not conducive to our model, and then we kind of mold it and we make it into something plausible, something that sounds okay, maybe isn't what's actually true, but close enough. And then rather than what you do, you know, the nice thing to do would be to take that model and then you kind of say, look, you know, let's talk about this, let's debate this. That's not what dentistry does. Dentistry takes that model, we set it on the heads of students, and then we mercilessly beat it into their heads until they accept, until they submit. And that's what doctrine is about. So I want to try to get around this doctrine and have everyone kind of set your beliefs aside just for a second, and then we'll kind of march through this together. There's a lot of beliefs in dentistry. And so beliefs are a great thing because you don't really have to have a complete cogent set of facts put together. You can just kind of pick and choose what you want. And so this is what we've done with perio. So just by a show of hands, how many of you were taught that bacterial plaque is like the primary etiology of periodontitis? Just, yeah, right? And so this is the thing that when you say primary etiology indicates what? Cause, right? So Basically what they're saying is cause and effect. Yet when you look at everything else that AAP and other research is putting out, no one's really saying that. Dental schools are teaching that, but that's not what the literature says, and that's not what even the professional organizations are saying. This is what I'd like to, all right, I don't know if I can get this to move here. All right. So if bacterial biofilms were the primary cause or etiology of periodontitis, then really this should be easy. We should just be able to clean the patients up, give them antibiotics, and everything will be fine. But as a periodontist, what I can tell you is at least 1 in 5 of my cases when I had the patients very compliant, doing everything that they were supposed to in terms of brushing, cleaning, presenting for regular maintenance, at least 20% of the cases didn't really respond as I really expected. Here's one of the cases. 59-year-old female, never smoked, good control of her blood sugar, dietarily, no refined sugar, low carbohydrates, gluten-free. I mean, she was a technician in a compounding pharmacy who was very holistically minded. Excellent oral hygiene. Let's see, I think they put my old presentation in here. All right, well anyway, she was diagnosed with fibromyalgia and rheumatoid arthritis, revealed further testing that she had elevated mercury and lead. I'm going to skip through this here. These are out of order. She had IV chelation therapy, but I don't know what the outcome of this was since she stopped coming to our office. And she also, so I don't have any radiographs to show in this particular case. But you could see that she was just continually losing bone. And so she would ask me, well, you know, I keep seeing more roots on my teeth. What else do I need to do? This is when I started to finally say, you know what, I need to be working with a different model here because this definitely was not working. And here again, this is the oral DNA results for the patient. Let me go back there a second. You could see that her, I mean, if you know how to read these, on the left-hand side, the high-risk pathogens, she had one high-risk pathogen which wasn't even really over the pathogenic levels. So, yeah, the question becomes, well, what was driving this? These types of what we call refractory, we used to call these refractory, but the AAP now, they changed all their designations now because refractory indicated that somehow we were failing and we can't have any failures. So now we call it aggressive. So even though the patient never had any increased pocketing, bleeding, nor calculus, still had loss, and we know from the literature that what I was seeing about 1 in 5, so 17%, just would not respond. So obviously I was missing something. The question is, was it something obvious? So we have some choices. When we have observations that don't fit our particular models, we can label it as an outlier and just ignore it. We can try to make our observations fit the model, which is what dentistry likes to do. We can develop a new model, which is what I worked on, with the question of, is bacterial plaque the primary etiology of periodontitis? Now we got a fourth choice here. Fourth choice, check our method of observing. So when we talk about perio, so many times we're really kind of hung up on pocket depths. But pocket depths and attachment loss are not the same thing. And this is the problem I was running into with this case, is that every time the patient would come in, pocket depths, 2s and 3s, no bleeding, everything was fine. Yet, patient's complaining, well, I'm still looking at more roots. So we need to be able to distinguish between pocket depth changes and loss or gain of attachment. So we have these two A and B here. Same patient. If you go from A to B, is there a reduction of pocket depth? So I'm going to call on one of the students. We've got some of our students over here. Huh? Was there a reduction in pocket depth? Great. Was there a change in attachment? Okay, how do you know that? How do you measure attachment? From the CEJ to what? Bottom of the sulcus. Okay? Which is what you got here. All right, great. Let's look at this. Change in pocket depth. Between the two cases? No change, right. Change in attachment? Absolutely. And that's what I was running into with that patient. Okay? Still had the same pocket depths, but attachment was being lost. So there are plenty of other observations that don't fit into this bacterial-driven model. This is Roy Page, well-known periodontist up in the Seattle area. I think he's retired now. But this is another form of this refractory periodontitis, very similar to the patient that I showed you. Excellent oral hygiene, never had increased probing depths, nor inflammation, yet they tend to lose vast amounts of attachment. Now, the patient that I had shown you, she didn't have any amalgams. She'd had amalgams previously, but she didn't have any at that time. You look at this patient, what do you notice here? Look at those class 5s. Gold and mercury class 5 restorations. You got a battery set up in there. Bacterial pathogens. How do we explain individuals who have no access to toothbrushes and oral hygiene yet they still seem to have good health? And there's multiple articles on this where they looked at hunter-gatherer tribes. Hunter-gatherer tribes, they don't have any toothbrushes, they don't have any oral hygiene, but they seem to do okay. Here's another article, same thing. This is in the Philippines. Genetically, pretty much the same, yet the hunter-gatherers don't seem to have big problems, but their brethren, who are traditional farmers, do, because they have a more refined diet. So this is the question. If anaerobes are found in clinically healthy individuals, are they really the drivers of periodontal disease? Or are they just opportunistic bystanders? This is by Curtis, Diaz, and Van Dyke, all well-known microbiologists, periodontists. Tom Van Dyke's a well-known periodontist at Forsyth, and they did this review article. Periodontology 2000 is kind of like this big review journal for periodontics, and they were invited to review all the literature related to microbiota in periodontal disease, and they came up with a few conclusions, a lot of which Perio wasn't really happy about. Dysbiosis is clearly associated with periodontitis, but we really don't know whether it's the cause or, whether it's just association. Molecular details, we still don't know how this happens. It should be noted that health-associated species are still present, and vice versa. This reinforced the principle that dysbiosis comes from changes in the dominant species rather than suddenly you have a pathogen that shows up to the party and then causes the problems. No, these guys are always there. So basically, this is just pointed out in this graph, that in health, you have these commensal bacteria and then you have the pathogens. Mind you, the health-associated ones outnumber the pathogens. But then in disease, suddenly both of them increase, but it's almost a race between the two. That is, it's almost even between health-associated and pathogenic bacteria. So this is the other question. Then if they're always present, then is this really an infectious disease? Well, in order for it to be infectious, you have to not normally have that bacteria present. And if these guys are always present, then it's not really infectious. So what could be the purpose of anaerobic bacteria? Anybody want to take a guess? I mean, what is the normal purpose of anaerobic bacteria in nature? They're the recyclers, right? I mean, if you go out to your compost pile, that's pretty much anaerobic bacteria doing the work. So this is the question, are they really pathogens? Whoops, sorry. Or are they the recyclers? Does this ratio occur because the patient has become recyclable? And that's what the bacteria are telling you. So really, all this evidence seems to point to the fact that there's something else as the etiological driver. The bacteria are just responding to conditions. They're not necessarily the drivers. Perio likes to think of it that way, but again, the evidence doesn't support that. Again, this is backed up by the AAP. Even 20 years ago, they knew this, which is interesting because, I've been teaching during all that time, and we never changed our position with the students. I mean, when they had to do their case presentations, always it was bacterial plaque is the primary etiology. Yet AP, when they put out their paper on the etiology of chronic periodontitis, which, by the way, never listed any specific authors, which I found really interesting. Normally people want to put their names on these things. This was kind of an anonymous report. And they say the factors that lead to the initiation of periodontitis are unknown. Pathology of periodontitis lesions are characteristics of and consistent with two things. Number one, a subversion of host defenses against bacterial plaque. So they're not saying the plaque causes the problem. They're saying that something happens to the immunological system that subverts the immune system. This is 20 years ago. The question is, what's causing this subversion? Second thing, subsequent activation of a bacterially induced host-mediated process that destroys periodontal tissues. What do we call a process that destroys its own tissues? Yell it louder. There we go. Hallelujah. But this is the phrase that Perio, even in Van Dyke's whole articles, he had plenty of opportunity to say the word autoimmune, but instead he uses all these other lengthy phrases because they don't want to say that. If you say autoimmune, suddenly now Perio has to completely change their thinking about the way they treat Perio. So they'll state it just about any other way that they can, a subversion of the host immune, they could just say autoimmune and be done with it. So can you have an autoimmune disease that has a bacterial component that makes the disease worse? Absolutely. Rheumatoid arthritis. All right? Where was that? Dave Reggiani. Yeah, we were talking about this earlier, right? I think Dave probably knew this, 30 years ago at least, right? 40. Okay, there you go. So do we treat rheumatoid arthritis with antibiotics? Sure. You can treat it. I mean, you can symptomatically treat it. There's literature to support that. Here, again, and this is just to point out the AAP has this mindset. They can't seem to make their minds up about what it is that they're trying to promote. They ask this question, is it contagious? I mean, if it's an infectious disease, it should also be contagious. Periodontal disease technically may not be contagious. Now, they spend all the rest of that little paragraph trying to convince you that it is, kind of insinuating, maybe you don't want to kiss somebody that's got perio or whatever. Well, but again, the evidence doesn't really support that. So again, patients can lose attachment. We need to be careful about conflating reduction of pocket depths with periodontal health. Periodontitis does not behave according to Koch's postulates. In fact, a lot of diseases don't behave according to Koch's postulates. If you look at these perio studies, I mean, my wife and I have looked at perio studies endlessly in animal studies. they always have to do something where they put like a ring or a piece of wire around the teeth in order to get periodontal bone loss, right, around the teeth. They can't just like put the bacteria in there and get the animals to get periodontal disease. Now they can breed animals that will develop periodontitis, but they are immunologically compromised. I mean, they're like knockout rats that they can do that. That should tell you something right there. So, research supports the concept that periodontitis behaves like an autoimmune disease with a bacterial component and not the other way around. So again, this is just repeating what the AAP was saying. So now we have to think about, okay, well, what's causing this subversion of the host immune defenses? So this is where we start to look at a more bioregulatory approach to this. Now, for the students and people, I know there's probably a lot of people here that are familiar with bioregulatory medicine, but for the students, this is a system, if I can summarize, it's where you're trying to re-regulate the patient. That is, normally the body in health has all of these various systems that are self-regulating. That's what keeps us going. So disease, though, is a result of a dysregulation in a homeostatic system. Example of this would be, where's Dr. Kakar? She's way in the back. See, you were trying to hide back there, yes. So what would be an example? Just yell it out. Some disease that is like it needs to be regulated on a regular basis. I'm sorry? Diabetes, right. Blood glucose. All right. Self-regulating system. And there's endless numbers of examples of this, all right? Point is, with bioregulatory medicine, they have to think about all these various regulations at various levels. And so bioregulatory medicine has these, what they call bioregulatory planes. Now, for us who have been trained initially as kind of allopathic, either physicians or dentists, it's sometimes a little difficult to kind of wrap our head around these bioregulatory planes. But what I found looking at this was when you look at their various bioregulatory planes, they tend to correlate with these hierarchical levels that we were kind of classically trained in. Structural, anatomical. The only one that really doesn't kind of match up, for me at least, is the psycho-emotional. But when you think about it, you know, at least in allopathic medicine, we try to manipulate the psycho-emotional with what? Biochemistry, right? We're constantly trying to manipulate brain chemistry. But this just gives you a means of trying to think about this, because when you look at the periodontal literature and you look at all these various levels, perio affects all of these various levels, from the anatomical through the genetic. And I've just put together a whole list of literature, and this is not meant to be, you know, an exhaustive list, but, you know, at the anatomical level, at the tissue organ level, microbiome level, cellular, subcellular, biochemical, and even at the genetic level. Now, associated with bioregulatory medicine, there's, Reykjavik's homotoxicology that talks about all these various levels of dysregulation. And strangely enough, I don't think that they have one for dentistry. Do you recall that, Phil?
Not specifically to organ systems.
Yeah. But at least for me, you know, looking at that, usually when you looked at that matrix, by the time you got, you know, any particular organ system, if it was dysregulated, the sixth stage was always like some form of cancer, right? But then when you see perio, how it's associated with all various types of cancer, you got to figure that perio is at that either the fifth or the sixth level of that dysregulation in homotoxicology. So just to summarize, you have these hierarchical physiological dysregulations that correspond to these bioregulatory planes, and that you have a lot of dysregulations. The point being that basically these, whoops, sorry. Oh, I think they got left out. Basically that these patients are really, really sick. And if you see active perio in a patient, well, if you're not really comfortable in trying to re-regulate someone's immunological system, metabolic systems, you need to be working with a functional medicine person or a naturopath or someone who then understands this and then can help you start to unravel this and start to get this patient re-regulated. See, I've got my functional medicine guy sitting right in the front row right there. She's all right, so we're trying to take these dysregulations and try to figure out how does this fit together. I mean, we've got all this tons and tons of literature, but we haven't really organized it in anything meaningful here. Now, pathology in the allopathic world is really, it's all about the cell, right? Cellular theory of disease. You guys know that thing about, that story about Virchow? Rudolf Virchow, he's considered like the father of modern pathology, developed all of the theories on cell pathology. And when he was developing this, this kind of supported the work of Pasteur and Koch and these guys. But as he got older and he started getting exposed to the work of these bioregulatory doctors, which were in Germany, Switzerland, Austria at the beginning of the 1900s. I mean, he lived till 1910. So this is like towards the end of his life. He's looking at this, and he had a famous quote basically saying, if I had to live my life over again, I would spend the rest of my life basically showing that all this work that I've done is not really relevant. He basically came to that conclusion towards the end of his life that the bioregulatory model of disease made much more sense than the cell-mediated. So again, when you're trying to see everything from the standpoint of the cell, it's like trying to understand the forest just by looking at the trees. So most of a cell's function behavior is based on how it responds to the environment, to the terrain. Oral epithelial cells are a good example of this. Epithelial cells are designed to essentially act as a barrier to the outside world, whether that's the epithelial lining of your gut or your skin on the outside, just meant to keep the bugs out or the rest of the outside world. Now, if you take epithelial cells in vitro and you put them into a medium, they basically try to start organizing themselves, but they can't because they're not connected to anything. They're not connected to each other, they're not connected to a basement membrane, they're not connected to a dermis. So what happens is that they start to become spindle-shaped and disorganized. All this research that we have on the virulence factors of things like P. gingivalis and for Treponema denticola, all these things are really based on in vitro research, and this is really misguided because you don't have any immunoglobulins, you don't have any adaptive immune cells or innate immune cells, and cells just lack their normal connections. To function properly, the cells need to be connected, basement membrane, connective tissue, all right. Even though the dermis underneath is really thought as more of an anatomical feature, it's very important. So the dermis is what determines the physical characteristics, regardless, bone, cornea. The other term we use, Phil? What do we call it? Extracellular matrix, see? That's the guy that taught me all about it. Anatomical space found throughout the mammalian physiology, found adjacent to every functional tissue in the body, often described as connective tissue, but it's much, much more important. It regulates lymphatics, neurological function, immunological, nutritional exchange, barrier structural, circulatory, and even genetic expression. Oxidative stress of the ECM, that is, the inability to clear toxins, plays a role in several diseases. We know that oxidative stress plays a role in periodontitis, yet no one's really looked at that directly. So does oxidative stress of the ECM have any effect on the adjacent gingival epithelial cells? Well, yeah. Barrier function is a direct result of the various junctions between cells. So if these connections between the cells are not properly maintained, then of course we're going to have problems. If it becomes dysregulated, if the ECM beneath the epithelial cells becomes dysregulated, we get too many toxins, too much waste, the normal oxygen exchange is somehow compromised, then things start to break down. And when those junctions break down, what do we call it? They get leaky. Just like leaky gut, you got a leaky mouth. You have this breakdown in the barrier function, allows opportunistic microbes to enter the nutrient-rich and somewhat toxic ECM. How does the host respond? Well, the invasion is initially monitored by the innate immune cells. Now, the innate immune cells on the epithelial side, like the Langerhans cells, when they see pathogenic, quote, what we call pathogenic bacteria, they're chill. They say, no problem, and they signal immune tolerance. However, if the dendritic cells on the other side of the ECM see those same bacteria, then the party starts. All right? It's just a repeat, sorry. But they start to signal these pro-inflammatory responses via their interactions with the CD4 cells. And then, of course, this starts down this pathway where you can start to get these various immunological responses. Th1, Th2, Th17. There's like 4 different pathways that CD4 cell can go down. And that's all dependent on the various cytokines that it's exposed to. Now, those other cytokines are signaled by these guys. So, perio, I mean, when I read the perio literature and it talks about Th17, IL-17 and IL-23 responses, it's all about, well, it's kind of pushing the patient towards, they don't even like to say it, a dysregulated immune response. They don't even like to say autoimmune. But no one ever really talks about, until I happen to find this article that talks about what the real purpose of IL-17 is. The real purpose of IL-17 is to regulate epithelial tight junction protein expression. So the body is trying to tighten up those junctions between the epithelia. They also help to induce antimicrobial peptide productions and release neutrophil chemoattractants. So they're trying to call in more cells to help break up whatever infection has managed to get into the dermis. Unfortunately, if this continues, that is, the leakiness continues despite the patient's efforts or their immune system's efforts to try to deal with this, then you get this big upregulation in plasma cells that start to infiltrate into the area. Langerhans cells, your innate immune cells, actually decrease. And you get increases in these plasmacytoids, dendritic cells, and then also, of course, big increases in neutrophils. Those are if you go to Barbara, oh, there, see? I say Barbara, and she walks in through the door. Yeah. If you go to Barbara's presentation, she looks under the microscope, and when you see these large infiltrations of pathogenic bacteria, you also see a concomitant increase in these white blood cells and these neutrophils that start to infiltrate in there. So, yeah, if you have a microscope and you see huge amounts of, spirochetes and these types of cells, and then also lots of white blood cells, you can pretty much be confident that that's a patient with perio with lots of problems. All right, to summarize, in health there's this balance between innate and adaptive immune cells. In periodontitis, you have this preponderance of pro-inflammatory adaptive immune cells, basically because there's this failure of the barrier of the epithelium to keep these guys out. So then the other question is, well, okay, if this is just inflammation going on, why do we have bone destruction? I mean, what's driving that? Well, when this interleukin response is unable to seal the breach, then you have these other pathways that start to kick in. And what happens is that you have this ratio of what's called rank L to OPG that starts to become unbalanced, and this starts to lead to this autoimmune bone destruction. You can go online, you can find all these neat graphics on this, that helps to explain this ratio. But the real key question for me then becomes, well, what is causing this chronic disruption of the epithelial barrier? That is, the body's trying to repair it, but it can't, so what's driving that? So this gets back to what the AAP was talking about. There's some sort of dysregulation of the immune system. Could it be that toxins are affecting both barrier and immune function? Are there any toxins that we know of that affect both? We know that certain toxins affect GI epithelial barrier function. One of them, of course, is mercury. So what we're really talking about here is immunotoxicology. This is, relative to research, this has probably been around for, 20 years, so it's relatively new. But I would say, very underfunded discipline, because, frankly, NIH doesn't really want to start pointing the finger at, toxins. Main risk factors that the AAP associates with chronic periodontitis are smoking and diabetes. Well, both of these, again, produce toxins that affect these homeostatic systems that, again, affect the ECM. Oxidative stress is another aspect to this. And, I tend to think of this as like barrier function, immunological dysregulation, and mitochondrial dysfunction. But if I had to pick any one of those three, this would be it. Chris Shea talks about this too. When I heard him talking about it, I was like, and he kind of feels the same way. It's like, yeah, if I had to point my finger at any one thing, this would be it. Because a lot of these toxins tend to affect the electron transport chain. Again, mercury, it affects everything. Barrier function, immune regulation, and even the electron transport chain. This is a Korean study that was done in 2009. Basically their version of the NHANES. Their conclusion, blood lead and mercury levels in periodontitis was significant regardless of the type of variable in the Korean male population. So basically, when we try to infer that bacteria are somehow responsible, you have to really look at these studies critically and realize that these are in vitro. This is not a real-world situation. Functional cells really communicate with each other to coordinate their function, so you can't really tear them apart, put them in with a bacteria, and then expect it to be able to defend itself. The specific characteristics and health of any tissue, extracellular matrix, we talked about that. Just repeating, sorry, I want to get my message across. Dysregulation of the host barrier and immune function is often the result of a toxicological burden that affects the ECM and its ability to exchange oxygen, nutrients, and cellular instructions. Okay, I'm going to stop there for a second because I threw a lot of stuff at you guys. This is and I don't want to say dumbed down, but I've tried to really simplify this as much as I could. There's a lot of components here that I've left out. Like if there were an immunologist or a cell biologist sitting there, they're going to sit there and go, well, what about this and what about this? And I get that, all right? My point is that I want to get across that we should really be thinking about this more as an autoimmune, especially if it's an all-out generalized perio. Now, if you've got someone with just localized periodontal attachment around 2 or 3 teeth, but yet all the other teeth seem to be fine, then I would say you really need to start looking at, well, what are perhaps the local factors? I mean, is it an endotreated tooth, for instance? So many times I get referrals and you look at the rest of the periodontium and everything looks fine and they have, but they have this 7 mm pocket on number 14. Well, you look at 14, endotreated, and you do a CBCT and you find, of course, it's got a crack in it probably. So you need to, I want to distinguish between like localized perio and then generalized. So what I'm talking about is more of a all-out generalized periodontitis. Pretty much all the teeth are affected. I think you have various levels below that, and the problem or the thinking that I want to try to get away from is trying to put everything in boxes. Nature does not necessarily accommodate our necessity for simplicity. That is, these are obviously very complex dysregulations. And trying to get our brains around, well, okay, well, like what do we do to treat this, I think has to be customized for each patient. I think you need to look at the other comorbidities that are occurring. I think this is why, again, you need to be working with the functional medicine or naturopaths on this because they're going to help try to ferret out what is it that's going on with the patient. They can start to do more specific testing, whether that's immunological testing. We were talking about Cyrex testing. That's where you probably need help in trying to really address it properly with these patients. Okay, so I'm going to stop here for a second. Questions on this? I just blew you guys out. Okay, yes. That's when we go into with the diagnostics. Okay, but thank you. Yes, we're going to go right into that because, all right, from the diagnostic standpoint, typically we've been really focused on the bacteria. And there's nothing really wrong with that, but again, we still have this kind of focus on the bacteria, and as I'm trying to point out, they're just the opportunists. They're not necessarily the drivers of what's going on here. It's not that it doesn't tell you anything, it's just that you could see in that other patient that she didn't really have a problem with biofilms. She didn't really have but she was still losing attachment. So let me go into this then. So in a patient like that, how do we discern if that patient actually has active attachment loss going on, or maybe there's something else here? So during this degradation of the ECM, we talked about the, let's see if I get the laser. No, all right. No. But anyway, we were talking about on the right-hand side, the dysregulated bone cells. But on the other side, it's showing where I have this circled, is where you have the neutrophils and the fibroblasts being affected by this whole dysregulation of the immune system, the IL-17, IL-23 cytokines. And you see that they are starting to produce then these reactive oxygen species, and then also, I don't know if I got that, these MMPs. MMPs are the matrix metalloproteinases. And there's all these various flavors, they're all numbered, but for like the past 10 years I've been following this research by this guy Timo Sorsa, who was able to isolate an active form, is able to come up with a test, because the matrix metalloproteinases are excreted by the fibroblasts and other cells into that ECM, but they're in a pro form, they're in an active form. It's not until you have the neutrophils starting to release things like myeloperoxidases and hydrochloric acid and things like that, that those MMPs start to become activated. So he was able to develop a test that actually measures the level of these active matrix metalloproteinases. So you're actually going to have that occurring probably even before you have the bone breakdown. So that's kind of an early warning system that things are already in this dysregulated form. Because if we're just depending on pocket depths and, even if you're checking the amount of recession and you're actually checking on the attachment loss, your patient's going to have to lose at least 2 millimeters of attachment before you physically notice it. So our ability to visually discern that is not really that great. So again, this is just describing that whole process. You can see the neutrophils, they're up there releasing these proforms of the matrix metalloproteinases, and then they get activated when the neutrophils get excited. So this active MMP8, years ago they had a device you could buy for your office, and it was about this tall, that you were able to process the samples. Well, it wasn't practical. But now finally, they've come up with a machine called the oralizer. And for this, you can then take either whole mouth salivary samples, you can do pooled sites, or you can do specific sites. I just got this machine like a week ago. It's interesting, but I'll have to report back to you on its efficacy in terms of its ability to actually pick up. One of my big interests actually with this was for the sake of using it to try to discern whether or not endodontically treated teeth were in an active state of breakdown. I saw Bill Birch's eyebrows go up like that real quick. Yeah, because anybody who does any of the ceramic implants, you get these patients that come in that have 5 or 6 endodontically treated teeth, and they want to get everything out. But I can't afford to do this all at one time, so let's just take out the worst one. Well, we're usually deciding that on a radiographic basis, but anybody who does this, that it isn't necessarily the radiographic appearance that makes it bad. So I'd like to start using this to try to go across these teeth and see how that matches up. Now, phase contrast microscope, I think this is a useful tool, but you have to interpret it properly. If you just see 1, 2, 3 spirochetes, I don't know that I would get that excited, especially if you don't have any white blood cells. But obviously, if you're taking a sample and you're seeing lots of white blood cells, lots of spirochetes, well, yeah, like I said, that's a no-brainer. But we still need research to kind of tell us, okay, well, at what level does this really become a problem? So maybe it's something where we can coordinate the phase contrast appearance with the MMP8s to try to see at what level do we start to need to be concerned about this. Because that whole system that I showed you, 100 tests, and the machine ran me about $9,000 to get it. So it's not cheap. And again, I'm not encouraging anyone to run out and get this thing. I'm just saying I find it really interesting, so I'm going to play with it for a while and report back. Again, this is my definition. You can make up your own if you like, but this is what I'm going with. Now for patients, when I talk to them about this, I tell them this is an autoimmune disease, again, with an infectious component, causes you to lose bone and gum around the teeth. For me, it's the result of toxins that inhibit your body's normal ability to generate energy, keep out and defend itself from microbes that constantly seek to recycle all of us. Oh, okay, sorry, this wasn't even supposed to be in here. She's still got my old presentation, so I'm going to stop there.